I as well wish to echo the thanks to all the people who have made this Congress possible. Here we are going to go back in time a little bit. This is somewhat historical in nature. Discography and in the diagnosis of discogenic pain goes back a number of years. It is not quite as commonly utilized now, but with the advent of intradiscal biologics, it may well become more prevalent as we need to qualify people for pain for intradiscal interventions. And then that will be contrasted with vertebrogenic pain, which will be discussed a little bit later in the morning. So I continue to have no relevant conflicts of interest. I do wish to acknowledge the founders of our society, McBogduck, Charlie April, and Rick Kirby. They were instrumental in writing all the basic science literature and the early clinical literature that led to the understanding of how the disc functions as a pain generator and how one may make a diagnosis of discogenic pain. So we talked a little bit about the structure of the lumbar disc yesterday, and now let's look inside that structure and see what's going on biochemically. There is a homeostatic situation here where the living chondrocytes in the nuclear compartment, particularly, but also in the annulus, control the synthesis and degradation of the nuclear matrix. That is, the constituents in this nuclear compartment, the proteoglycans, collagen, and bound water, which allow the nuclear compartment to bear axial load and disperse it radially where it's constrained by the fibrous annulus. But unfortunately, these chondrocytes live in a very nasty neighborhood. This is a hostile biochemical environment. There's no direct blood supply in the adult. All nutrients diffuse across the cartilaginous vertebral end plate. Has very low oxygen tension, and they essentially exist with anabolic metabolism. And any variety of insults can upset this homeostatic balance of synthesis and degradation. And some of those insults might be metabolic disease, such as diabetes or ochronosis. Genetic factors play a significant role, as I'll mention in a few moments. Traumatic end plate injury is key, and also nutritional insults instilled by smoking or vascular disease and infectious agents. Here was an elegant twin study done by Michel Vattier some years ago showing that familial aggregation, that is genetics, has a significant role in the evolution of disc degeneration. So when your back hurts, blame your parents. That always works. So we're talking here in maintaining the health of that nuclear compartment and its ability to function. We're talking about the balance of synthesis and degradation of its molecular components. This is a little busy, but we'll just walk through it quickly. The chondrocyte in the nuclear compartment, through growth factors, stimulates the synthesis of collagen, which predominantly makes up the fibrous annulus, as well as proteoglycans, and those proteoglycans and collagen make up the nuclear matrix and allow it to bind water and accept axial load. But those chondrocytes also control the degradation of those elements through TNF alpha and interleukin 1, mediated by superoxide and nitric oxide. They will degrade those proteoglycans over time, and metalloproteases will also contribute. And there has to be a balance of this synthesis and degradation to maintain the health of the nuclear compartment. And what happens when degradation becomes is favored, that is, there's an imbalance of synthesis and degradation? Well, we see a number of changes extending from the molecular level all the way up to the macroscopic imaging level. And what we see macroscopically on imaging is loss of T2 signal in the nuclear compartment on MRI. So this cascade of change is the final common pathway of the response to any insult. And it is not, it correlates, it's ubiquitous, it's extremely common, it correlates only with age and not specifically with pain. And it's commonly present in asymptomatic subjects. Up to 50% of young adults will have these findings, and everyone in this room has at least one lumbar arm disc, I would wager. So let's step back for just a moment and talk about why we image the back pain patient. The primary role of imaging is the detection of underlying systemic disease, whether it be tumor, infection, spondyloarthropathy, or fracture. And we do know how common that is. About 5% of patients who present with back or limb pain when they have advanced imaging will have a systemic cause of that. But because of the low prevalence of systemic disease, that is 95% of patients will not have any systemic disease, most of the findings we'll see on imaging will be so-called degenerative or age-related change. And this challenges the specificity of all imaging, and we'll see this expressed particularly in degenerative findings in asymptomatic subjects. And here is a table of many of the studies going all the way back to radiographs, myelograms, CT, and MRI, all on asymptomatic subjects. None of these people have back pain. But look at the prevalence of disc degeneration, that is loss of T2 signal in the disc. It's very, very common, and when it's stratified by age, it's ubiquitous or nearly universal. At my age, everyone has dark discs. It's a normal phenomenon. And disc herniation is also a very common asymptomatic imaging finding. Just in young people, there's a nice body of literature from Scandinavia. Age 13-year-olds, 20% have dark discs. Age 15, 30%. Age 18, 40%. As a young adult, about half of subjects have dark discs. So they've undergone some of this cascade of imbalance of the synthesis and degradation, which does not in and of itself cause pain. Now, in contrast to that normal aging phenomenon, we have internal disc disruption. And this is a very specific entity characterized anatomically by isolated radial fissures in the disc. These extend from the nucleus pulposus to the annulus fibrosus. And this is not age-related change. And this does correlate with axial or so-called discogenic pain. And of the several insults we talked about earlier that will cause that imbalance of synthesis and degradation, the one that seems to be predominant is end plate fracture or end plate fatigue fracture in that end plate. End plate fractures or infractions over time will cause reduction in the volume of water and proteoglycans in the nuclear compartment, delamination in the collagen lamellae of the annulus, and ultimately reduction in pressure in the nucleus. We're going to go a little bit over some of the fundamental literature that identifies this. So you can recognize how much effort has gone into this process of understanding this over the last several decades. So when we apply cyclic stress to a motion segment in vitro, over time we will see a end plate infraction or fatigue fracture, and that will result in depressurization of the nucleus. How do we know that? Well, when you use cyclic loading on an in vitro motion segment, that is two vertebral bodies and an intervening disc, using cyclic loading at levels of load which are not supraphysiologic. These are physiologic level loads. We will see end plate infractions. And we can demonstrate their effect by an old technique called stress profilometry, which will measure the distribution and magnitude of stress within and across the disc. And this is a very simple technique, simply a pressure probe with a measuring aperture is inserted in a normal human from the posterior annulus across the nucleus to the anterior annulus, and then slowly withdrawn and measure pressure. And when we do that, we're going to see a profile that's going to look like this. In the anterior annulus, the pressure is maintained as we go across the nuclear compartment, and we have a little more pressure in the posterior annulus. So this is the healthy state. And when we have an end plate infraction or fracture, now we see the depressurization of the nuclear compartment, and we have increased load being borne by that posterior annulus. And ultimately, the nucleus becomes entirely depressurized. So with end plate fatigue fractures, we see degradation of the nuclear matrix, and this stimulates an inflammatory response and simply accelerates the nutritional and biochemical insults, because now the fractured or otherwise injured end plate is not able to allow transmission of nutrients and oxygen by diffusion across this now compromised end plate. So we see nuclear dehydration. It can no longer bind water, so it can't accept axial load as it did prior to this insult, and it can't disperse that load to the annulus. So now the load, rather than being borne by the nuclear compartment, is transferred dominantly to the posterior annulus. Now, if that annulus remains intact, it survives, so to speak, the physiologic response will be the generation of osteophytes as the vertebral body attempts to spread that load out further. But if the posterior annulus fails mechanically, then we will have the evolution of annular fissures. When we have excessive load on that posterior annulus, we will have failure of the internal bracing of the pressurized nucleus. When the nucleus is pressurized, those annular rings are supported from internally. And when it's depressurized, they can buckle inward and tear. And that will result in these annular fissures. And the characteristics of these radial annular fissures are they're most common posterolaterally. They're single or relatively few, and they are the unique lesion anatomically of internal disc disruption. So here we have the nuclear matrix. When it undergoes degradation, we'll see the evolution of fissures extending usually posterolaterally, and they may extend all the way out to the outer annular lamellae or layers and dissect circumferentially. And why is that important? Because out here in the outer third of the annulus, they will now encounter the normal nociceptive supply of the disc. We measure this, or we quantify the depth of these annular fissures on CT discography, where we've instilled contrast material into the nuclear compartment, and then we can see it spread out into the outer annulus. And we grade them on this Dallas discography scale. Grade 1 is extension to the inner third of the annulus, grade 2 to the middle third, grade 3 to the outer third, and grade 4 when we see circumferential extension. Here's an example, a patient with a small disc herniation at the L4 level who has only axial pain. Otherwise, these discs look really reasonably healthy on MRI, a normal internuclear cleft. But when we do a discogram, that is replacing a small caliber needle into the disc from a posterolateral vector, and then distending the disc, subjecting it to the same sort of axial load that it would experience when you're bearing your weight, and that which we are instilling into the disc is contrast media. We can look at the lateral view, and this doesn't look too bad. This is what we expect to see, contrast in the nuclear compartment. Here we can see some leaking posteriorly, as well as here. But on the CT studies, post-discogram, now we can identify that there are indeed annular fissures extending to the outer third of the annulus at every level, despite the MRI being relatively normal. Now, what does this correlate with pain? Well, these are patients who had stress profilometry, and when there was increased stress on the annulus, those patients had pain. When the nucleus was depressurized, those people had pain. So this goes back, 25, 30 years, but it does indeed provide the physiologic basis for what we ultimately know about how discogenic pain is generated. So we do have evidence that pain is associated with grade 3 and grade 4 annular fissures. Fissures to this extent, to the outer annulus, allows access of this nuclear material to the nociceptive apparatus in the outer third of the annulus. We may have chemical stimulation of those nociceptors, usually by nitric oxide, a component of the degraded nuclear compartment. And we also have excessive load on the posterior annulus, so we may well have mechanical stimulation of those nociceptors. And when we have annular disruption, which extends, which involves grade 3 fissures, and we then pressurize that disc, we will typically see reproduction of the patient's typical pain. So we pressurize the disc. Mrs. Jones, Mr. Smith, what are you feeling? Oh, I feel my typical pain. Or I feel nothing. So this is a very subjective diagnostic test. And when there are no fissures, we tend not to see pain. It's not perfect, obviously, but there's a clear and statistically significant trend. And this has been repeated multiple times, a study by April and Bogda, again showing the same thing. So what are the clinical findings suggestive of discogenic pain? This occurs in younger patients, generally less than 45. It develops usually with insidious onset, not the result of a specific trauma. Aggravated by axial loading. Sitting intolerance is typical. It's difficult to sit, relieved by laying down. Generally localizes to the midline, although it may cause referral to the upper thighs and even below the knee in about 20%. And patients often have difficulty straightening from standing flexion. They have a hard time going from this upward, and you'll often see them kind of supporting themselves with their hands as they work to reach extension. Just to provide overall context, this is a nice Venn diagram from a publication by colleagues of mine. And here is disc pain, and notice that it overlaps significantly with facet pain, but facet pain tends to be in an older age group, and disc pain tends to be in a younger age group. So we've talked about pain provocation, which implies that there's disc innervation. And believe it or not, when I was in medical school, 45 years ago, 50 years ago, this was controversial. It was thought that the disc was not innervated. But in the 80s, 90s, this was indeed identified. Initially in 1980, Yoshizawa identified neural innervation in the outer annulus. And then this was really solidified by Nick Bogda from Ipsos in the early 80s. And he really defined the present understanding of the afferent signaling from the disc. We talked about this yesterday, and recall that the sinovertebral nerve extends back into the ventral epidural space and provides innervation to the outer annulus, and that extends around as a gray rami communicans, providing innervation to that outer third of the annulus. But then also note that when we have these annular fissures, if they extend to the outer margin of the annulus, they will stimulate an immunologic reparative response. And we'll see the ingrowth of blood vessels into that disc, and with those blood vessels comes neoinnervation. So we'll have additional innervation into the outer annulus as the body attempts a reparative response. So the criteria for a positive discogram, we have a combined CT discography imaging and concordant pain. It's the real crux of the matter is, can we reproduce that patient's typical pain, both in its location and character? This was a study done by April and Walsh back in 1990, and the critical point here was, if you do this stimulation or provocation discography test in asymptomatic subjects, will you produce pain? And the answer here was no. These are all asymptomatic subjects. About 20% of the discs had structural abnormalities, and 50% of the subjects had some structural abnormalities, but all the discs were non-painful. So the test itself is intrinsically not painful in an asymptomatic subject. That is, there were no false positives. Rick Derby expanded the understanding by using manometric control to improve the specificity of this stimulation, essentially showing that when we have reproduction of typical pain at low pressures of injection, that is more relevant, but we can have reproduction of pain up to 50 psi above the opening pressure, and that is also within the realm of diagnostic importance. Above 50 psi, if you continue to inject with greater pressures, you can make anybody hurt. So you have to be thoughtful and careful and manage the pressure with which you inject. So we do have a gold standard dilemma in terms of discography. We do not have any pathological standard. We cannot take out a piece of disc and look at it microscopically or histologically and say this disc was painful. That's not possible. So how can we use an intervention, provocative intervention, to make a diagnosis? Well, when we look at a test, we always have to look at our 2x2 table And here we have a challenge because we won't have cells A and C, because we do not have a reference standard. So we can maintain some validity if the false positive rate, that is B, is very small, and here the reference standard is asymptomatic subjects, and that's what the Walsh April study helped us with. Wolfer and Gertie also looked at a meta-analysis of 11 studies to verify that we were not having false positives. And they looked at all the pooled data, and false positive rates per disc and per patient were very small, even in chronic pain patients. So what is the utility of discography? What's its usefulness? What does it achieve? Well, if we would like it to have therapeutic utility, that is, it has predictive validity, does it predict the outcome of a subsequent intervention? So if we have a diagnostic test, we would like to be able to construct the 2x2 table and compare it to a treatment outcome. Does the diagnostic test predict the treatment outcome? For example, intervertebral fusion. Well, this has only been done in one study, and the challenge to that study is there are relatively few patients done with a negative disc stimulation. Here we would be asking a surgeon to go ahead and do a fusion without using the discogram data as a selection criteria, and unfortunately no surgeon is likely to do that. So we will probably never have that data. But we do have negative predictive value. When disc stimulation is negative, we don't operate. When disc stimulation is indeterminate, we don't operate. When disc stimulation is positive at multiple levels and the risk of a surgical intervention is high, we avoid that risk and do not operate. And we also have to convert that operation now into other intradiscal interventions. As new intradiscal interventions such as the biologics have evolved, we're not going to see, we will use discography to not use this inappropriately. So disc stimulation is a barrier to excessive surgery or other interventions. So when it's negative, we will not do these things because we know they will not be helpful to this patient. And it provides us with closure. So oftentimes in interventions for axial back pain, we have kind of a circuitous pathway. And we're trying to make the diagnosis, and if we don't have a diagnosis, we try various things. You know, is it the facet? Is it the SI joint? Is the patient just deconditioned? Does the patient just have a bad attitude? Is it myofascial pain? Do they not have had enough steroid injections? But once we have a diagnosis of internal disc disruption, even if we do not have a good treatment for intradiscal mediated pain, we can interrupt this circus and not perform unnecessary and unhelpful interventions. A couple of cases to illustrate this. Here's a patient with where we did the provocative discogram, a 25 gauge needle into the disc, instilled on less than 50 psi, injection of contrast material. And this is a completely normal disc at L3. Contrast remains confined to the nuclear compartment. At the L4 level, we see contrast extending anterior and posteriorly throughout the disc. And on the CT, we can see this is indeed circumferential extension around the disc. And the L5 disc as well is relatively normal. The patient had no pain reproduction at L3 and L5, but had reproduction of a typical pain, both in terms of its location and character at L4. So here we can make a diagnosis of internal disc disruption at L4. Now, what do we do with that? That remains a question because we do not have a validated, high-quality therapeutic intervention. And we do have a scoring system, which I will not dwell on. Here's another patient who had chronic axial pain, failed conservative therapy, and note on the MRI, we do have some loss of T2 signal and small disc herniations at L4 and L5. L3 looks completely normal on the MRI. We do the provocative discogram. This is a completely morphologically normal disc, but the patient had 10 out of 10 pain. The L4 disc has an annular fissure, so this is a grade 4 disc as well. Grade 5, sometimes we include that when we have leak into the epidural space. and this patient had 10 out of 10 pain there. And at L5, we had complete disorganization of the disc, and the patient had 20 out of 10 pain. When patients have pain at every level, I know nothing. There has to be a negative control level to kind of set the boundary that this patient is not psychologically incapable of having a normal, non-painful disc. So in this setting, I'm going to tell my surgical colleague that this was kind of my report. I cannot make a diagnosis in this setting. Do not intervene in this patient. Nothing good will come from intervening surgically or minimally invasively in a patient with that sort of an outcome. You might suspect that in the 21st century, why are we resorting to an interventional diagnostic procedure? Why can't we do this with imaging? Well, we do have two pretty good imaging biomarkers. We have modic 1 or 2 change, which we see here, modic type 1. We have T2 hyperintensity and T1 hypointensity, that is marrow edema. That is the most active inflammatory state. Modic type 2 is simply fatty infiltration. It's bright on both T2 and T1. And then modic 3 is simply sclerosis, dark on both T2 and T1. And modic 1 or 2 with a significant expression, that is 25% of the vertebral body height, that has a pretty good prediction, a likelihood ratio of 3.4, nearly 70% chance of a positive disc stimulation. That's not a bad biomarker. The high intensity zone described by April and Baca, a small zone of T2 hyperintensity in the posterior annulus of a disc which is degenerated. It enhances, as we see here when we give them gadolinium, indicating this is a vascularized structure. And when we do a CT discogram, we can see that there is a fissure at that level as well. This has an even higher likelihood ratio and is again greater than 70% predictor of positive disc stimulation. And a number of novel MRI biomarkers have been studied over the intervening last 2 decades. None of them, however, have found their way into standard clinical practice. So, in conclusion, the disc, it suffers inevitable, non-painful age-related change, often inappropriately called degeneration. Better simply to say normal changes of aging. Internal disc disruption, in contrast, is a distinct disease process, causal of pain, emanating by the internal and neo-innervation of the outer annulus of the disc. And disc stimulation or provocation discography is now the reference standard for making the diagnosis of internal disc disruption. It has negative predictive value, prevents unnecessary surgery or unproven interventions. It has diagnostic value when positive. It provides closure, preventing overtreatment for other entities, and preventing other unnecessary investigations or interventions. And it is very much a story of Ipsos physicians. April, Baca, and Derby, and many others contributed virtually all the important literature in defining the innervation of the disc and proving the physiologic nature of pain emanating from the disc. So thank you very much for your attention, and I hope this has been of value.